A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, work with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
Very good evening to all of you. Warm welcome to this 60th International Webinar Series of CAHO, which we do on the first Tuesday of every month. And we're really fortunate that we have some wonderful international speakers, experts who join us to share insights on various topics in healthcare. Today also we have a very special session, which is on clinical governance framework, something that's been a talk for quite some time. A lot of clarity to be brought about in all hospitals regarding that. A struggle, I must say, but which most of our Indian hospitals still have, and we are still getting there. I'm Dr. Anna George. I'm actually the group head of quality for Aster, DM Healthcare in India. I'm also a governing committee member of CAHO in the capacity of secretary for the Quality Professionals Division. And to take you through this today's session, for the introduction and the welcome of our international speaker, we have with us Dr. Prema Vadyar, who is an accomplished healthcare administrator and digital transformation leader with over 13 years of experience spanning clinical practice, hospital operations, and healthcare strategy. She is currently the lead of clinical services at HCG Cancer Care, which is Southeast Asia's largest private cancer care network. She has led enterprise-wide digital transformation innovatives that enhanced clinical workflows, operational efficiency, and patient outcomes. An IIM Bangalore alumnus and NABH assessor, she has been instrumental in developing policies, process excellence frameworks, and quality improvement systems across multiple hospitals. Dr. Prema is widely recognized for her leadership, innovation, and commitment to advancing quality and patient-centric care in oncology and healthcare management. A warm welcome, Dr. Prema, to you, and over to you.
Thank you. Thank you so much, Dr. Anna. Good evening, everyone. And once again, welcome to 60th session of CAHO-ISQua webinar series. This esteemed international CAHO series has been running for almost 4 years now. And today's session focuses on establishing a clinical governance framework in hospitals, a crucial area for improving safety, quality, and accountability. It is my pleasure to introduce Ms. Gillian Giles, Director of Healthcare Variation at the Australian Commission on Safety and Quality in Healthcare. She leads the national team responsible for the Australian Atlas of Healthcare Variations and works on improving the appropriateness and equity of healthcare delivery across Australia. With a clinical background in speech pathology and extensive experience in state and Commonwealth health systems, she has contributed significantly to health policy, service planning, and quality improvement. Her work strongly reflects evidence-based practice, transparency, and value-based care. A warm welcome to Ms. Gillian Giles. And the session flow would be like, it will include 35 to 40 minutes of presentation, followed by 10 to 15 minutes of interactive question and Q&A session. I would request all the audience, if you have any queries, please use the option available Q&A at the bottom of your screen, and you can post your questions that we can take it at the end of this session. Okay. Now I would request Ms. Gillian to take over and start the session.
Thank you, Dr. Prema. Thank you for your kind introduction, and thank you all for having me. It's a great honour to talk to so many of you and so many experts from not only India, but I can see from around the world. So we have started an exciting piece of work in the Commission, and I now have a new role since your introduction. I'm now the Executive Director of Clinical Governance, and this is a new piece of work for us as we look at reforming how Australia views clinical governance. So today I'm going to talk to you about our new national model of clinical governance and how health services can then adapt that and use that to create their own clinical governance frameworks. This is a very new piece of work for the Commission. It's in draft at the moment, and we will be releasing it early next year. But it reflects a very big body of work where we have consulted across Australia and internationally in order to work out how best to support the system. So I will share some slides. Okay. So I'm going to talk to you about why we've developed this new model, how we've gone about developing it, and then what it looks like. So in starting this work last year, I spoke to health system leaders across Australia and also across the world. And I was asking, we did a series of interviews and we asked health service chief executives and hospital board chairs about what was working and what was not in clinical governance. And we heard some terrible stories as well as some stories of success. This is hard and this is complex. And I was struck by the stories that these very senior people who have been working in the health system for decades told me. So I had a board chair describing sleepless nights after a failing in one of their outpatient clinics, which led to it was in an audiology outpatient clinic, and it led to the failure of thousands of newborn babies missed out on their hearing screening tests, and just the description from the board's perspective about the complexity of a risk around this, and how this wasn't even one of the sort of key risks that they were focused on. This was on the boundaries of their organisation, and just the distress that that caused the entire community. I also spoke to the chief executive on the right of a very large hospital in Victoria, in Melbourne, Australia, who talked about just the effort required day after day after day to build a strong culture in his hospital, and how quickly that culture can be evaporate overnight with an incident. So just the sheer effort required to build and sustain culture day after day after day, and then how quickly that can just deteriorate in an instant. So it's just the effort of these roles. So a little bit of contextual information before I dive into the work. So in Australia, our health system is predominantly run by two levels of government. So our federal government funds states and territories to run our public hospitals, but the federal government is also primarily responsible for primary care and our general practices. The state governments then run and the operational aspects of public hospitals, and they also regulate these hospitals. And we also have a thriving private sector as well. So in my role at the Australian Commission on Safety and Quality in Healthcare, we have a big health system remit. We span the entire health system, so we're a safety and quality advisory body, and we are jointly funded by not only our federal government, but by each state and territory government. And our main piece of work, as I'm sure most of you know, is that we're responsible for developing our national safety and quality health service standards, and these are mandatory for all hospitals and all day hospitals in Australia, whether they're public or private. And one of the key areas of focus in our standards is clinical governance. It's the first standard, and it's designed to underpin the implementation of all of the other standards. So in starting this work, we were asked by states and territories to prioritise clinical governance, and what they asked for was a renewed focus on clinical governance. We knew from our data that it was the standard that most hospitals failed or didn't pass at first accreditation survey. It was by far and away the most difficult standard for health services to meet. And we also knew that in terms of I guess a sense in post-COVID and the complexity of the health system right now, and workforce shortages, and the constraints in budget on the health system, we knew that strong clinical governance was more important than ever. So there's a few reasons why we focused on this work. So in order to understand the problem, we conducted a needs assessment to really, where we consulted with people across the country to really understand what was and wasn't working from their perspective. On the top left-hand side, you'll see that in the public sector, we interviewed board chairs and chief executives. So we asked each state and territory government to nominate high-performing health services in their state or territory who they considered did well in clinical governance. We then paired that with our data that we sit on from our national safety and quality standards and our accreditation data to check and verify that they did in fact perform well in clinical governance. And then I conducted interviews separately and individually with each board chair and each chief executive to hear their perspectives on, to learn from successful leaders, but they were also very frank in telling us what wasn't working and what was difficult and what made their jobs hard. We also then met with all of the key private hospital ownership groups in Australia, and we ran a series of focus groups with representatives from each of those. We met with peak organisations and from across Australia. So this was some of our First Nations health organisations, our consumer peak groups. We have safety and quality experts and governance experts, academics, as well as then clinical leaders from across the system. So we met with presidents of our key clinical colleges and associations. We met with different medical, nursing and allied health groups across the system, and then safety and quality experts. We combined that with a rapid literature review where we were interested to understand contemporary definitions of clinical governance from around the world. And we also looked at then themes in Australia from safety and quality failings. So when there were inquiries into safety and quality incidents, we looked at common themes arising from that. As I said, we also looked at our accreditation outcomes data, and within our clinical governance standard, we drilled down on what specifically was most difficult for health services. And then we also met with representatives from each state and territory health department and to understand what work and what initiatives they had underway in their areas. So what do we hear from all of this? I would summarise it in the top 3 themes above the line, and I'd be very interested to hear if this marries up with your experience and experience internationally. Firstly, quite frankly, clinical governance is not well understood. There's a lot of confusion about the term. Clinicians don't find it meaningful. They told us that they thought that this was the domain. So doctors would say, oh, this is the responsibility of nursing staff. Or perhaps this is just to do, nursing staff would say, oh, this might just be how you might escalate an issue. And I think what was missing in clinical governance was it's lacking in purpose. And so it was seen as a bureaucratic exercise to get accredited. And when health services perceived it this way, we saw this second theme of this really strong compliance approach, where because it was clinical governance was divorced from purpose, the purpose wasn't seen as an enabler for delivering high quality care. If the purpose was purely to tick some boxes and to get accredited, it was perceived as a burden. And we often saw as a result when that was the case, that there was an excessive focus on processes rather than outcomes or impact, excessive data collection. We heard about data reports that would go up to health service boards that were 120 pages of dense data lacking in any kind of synthesis or key messages or visualizations, not translated for clinicians or translated for board members or decision makers who didn't have a clinical governance background. And then we also heard about excessive risk registers. So risks that were endlessly documented and added to very long registers and lists that were quite static, not dynamic, and leadership teams and boards were not looking at them strategically to synthesize and pick out common themes and look at how risks from across an organization, when they looked at it at an aggregated level, how they could pick up what was happening across an organization to build a really detailed profile. And then thirdly, we heard about too many silos. So at its worst, you heard about clinical governance or safety and quality being delegated to a quality team and other people didn't see it as their responsibility. Or you saw a very piecemeal siloed approach where you had a medication safety team, an infection control team, and all those sorts of fabulous teams, but a lack of integration and communication across all of these teams, and a lack of sort of organizational wide learning about all of those things. So what was needed? We heard very clearly that the Commission for many years has focused on developing resources to support quality managers and clinical governance experts, but we actually heard from boards and senior leadership teams and chief executives that they wanted practical guidance on what clinical governance was and how they could better set up their systems and structures and culture to deliver high quality care. People were also very interested in more contemporary guidance on new topics of healthcare. So in Australia, cultural safety is a very big one. So the cultural safety of the healthcare that our First Nations, our Aboriginal and Torres Strait Islander patients receive. So is it appropriate and is it safe and is it high quality for our Aboriginal communities. We also had a lot of requests for more advice about digital health, AI, and then the proliferation of new models of care. So particularly in primary care, where there's just so many different and evolving models and new virtual care models. And then finally, we were asked to bring in a contemporary feel to our advice. So looking at contemporary best practices internationally on good governance. So this was things like, instead of talking about duties and responsibilities, this was more about shared accountabilities across an organisation and having leadership teams, boards, clinicians who were there were accountable to the communities that they served, and really flipping the focus on how they were supporting patients and communities, rather than the insular focusing on the machinations of how a health service or a hospital works. And the other big piece of work it's much newer since our original work in this space is now that there's very, very strong link, which I'm sure you're all only too familiar with, between a strong workplace culture and a workforce that where well-being and a positive workplace culture is encouraged, and the direct link between that and the quality of care that our patients receive. So we understood the problem after all of that, and our solution is multifaceted, but the very first part of what we're doing is developing this new national clinical governance model. So it's designed to reshape Australia's approach to clinical governance in a changing environment. And really what we're wanting to do is give health service leaders the tools they need to review and strengthen their own clinical governance arrangements, and to identify what their organisation needs. Our audience initially is for boards, health service boards, and chief executives and senior leadership teams, and it's for the acute sector. We have plans down the track to look at what we could draw from this for primary care, for virtual care, and for other healthcare settings. But to start with, we're trying to get this right for the acute sector, and then we'll build on that. So we've redefined clinical governance because of that problem that I mentioned earlier, where people just did not find the definition of clinical governance was not meaningful. It hadn't landed. And so our draft definition that we're playing with at the moment, and we will refine this, we start with the purpose of clinical governance. Clinical governance is central to providing the best outcomes for patients. So it's not about getting accredited. It's not about checklists and complying with processes. It's actually about the quality of care that our patients receive. So framing the definition with leading what the purpose is at the outset. And then we describe it as, we've slightly updated it since this, just in the last couple of weeks, since I wrote this slide. We're describing it basically as the combination of culture, systems, and structures in an organisation that enable everyone in that hospital or in that health service to deliver care that's constantly high quality and improving. When I get to the end, I'll be very interested to know whether that makes sense to you. And this is what it looks like. So we've drilled down and to focus on the 6 things that we think are essential in how you run a hospital. We describe it as a set of 6 core foundations, and when you combine these 6 areas, they underpin an organisational approach to delivering high quality care. So each of these wedges in this wheel are all supposed to be interconnected and dynamic, so they can change, they can contract, they can expand according to situation, according to context. And in this way, our national model can be adapted at a local level for local hospitals to develop their own clinical governance framework or model. We've deliberately put the first foundation bigger than the rest, recognising that leadership and leading culture and systems is essential for the success of all of the other 5 foundations. So the 6 areas that we've pulled out are leadership and organisational culture, firstly, because we're recognising the role of the board and the leadership team in setting the culture and strategy for their organisation, for their hospital. Secondly, the partnership with patients and carers and consumers. We're talking about how governance in this section about how governance systems need to provide care that's person-centred. So pulling it again back up to purpose. Building a healthy workforce culture I mentioned before to reflect that very strong evidence we now have about the importance of this on high quality care. And then the 4th foundation is on clinical care. So we've called it enabling high quality and integrated clinical practice. 5 is managing and reducing risk, and 6 is using data for better care. And you'll notice they're all framed in the positive. It's about what we're wanting from each of these. We haven't just called them data, risk, clinical practice. It's about what we expect. And these really are the 6 areas where we found were most often were the problems that we heard about in our needs assessment. That excessive risk registers that didn't get to the heart of the problem, or excessive collection of data without people actually acting on the data and making improvements. So that's the case for change. So really, these 6 things are quite simple. I'm sure none of them are very surprising for any of you. They're not complex. And under each foundation, we've got some simple descriptions about what good looks like. We've got some warning signs about how you might know if you've got a problem in any of these areas. And then we've got some examples of best practice under each one. And the point is that a board or a leadership team can check whether their hospital's activities are aligned with each of these foundations. And it should give them a sense that if they can say that their organisational culture, their organisational systems and their organisational structures are all oriented to these 6 areas and focused on high quality care, then we'll know automatically that they're going to be doing a better job. We've tested this with hundreds of people over the last few months, this draft, and we've gone to some of our very small hospitals in outback Australia in very remote areas, and we've also taken it to our very large metropolitan hospitals. And I've been surprised often when you take out something that's quite different and you're consulting, you get prepared for negative feedback. But we have had overwhelmingly positive feedback. People like it. It's simple, it makes sense, and we're going to support these 6 areas with a whole lot of practical tools. And yeah, there's been a lot of enthusiasm, so I've been pleasantly surprised. So what the model is and what it isn't. So it's high level, it's principles based, and it's really these 6 areas are the core areas of focus that we think executives should be focused on to help get the basics right. And the reason that it's principles based is that it's the opposite of a prescriptive approach. We then want local health services to adapt it so it's fit for purpose and context for their local communities and their local environment. So what it's not, it's definitely not down in the weeds, looking at processes without considering impact and outcomes, looking at collecting risks without doing anything about it. It's certainly not prescriptive or compliance-based, and it's not siloed. We're trying to show the relationship between all of these things. So then what else will we do to support this model? Because the model is just the start. It's the signal to the system on the reform we want and the change in direction that we want. So the Commission is about to update our National Safety and Quality Health Service standards. We're about to, it's a 3-year program of work to release our next edition, which will be our 3rd edition. So we're looking at how we structure the next clinical governance standard. And what we're going to do is align the next clinical governance standard with each of those 6 foundations I showed you in the graphic, so that actions in our national standards will fall within those 6 headings. And then that way you've got your board and your executive focused on these 6 areas and thinking about those at a strategic high level perspective, but then you've also got your entire workforce working on actions that are aligned with each of those 6 foundations. So you've got a lovely board to ward alignment where everybody is talking the same language. So that's the exciting part to this model, is that it will then be built into the next standards. And actually, one of our very first actions in the next standard will be that hospitals must have their own clinical governance framework based on this national model. We're also working madly on a whole lot of practical resources to back this up. So we're going to have a guide for boards on best practice approaches for creating culturally safe partnerships. That's in terms of our First Nations communities. That's just, we're going to have a whole lot of other resources. We're going to have a how-to guide. So if you're the general manager of a hospital and you've been in your role for one day and this national clinical governance model lands on your desk, where do you start? What do you do? So we're going to have a simple self-assessment tool, very simple, so you can work out and conduct some activities with your leadership team and your board about where your strengths and where your opportunities for improvement are. And then we'll just have some very simple practical resources for each of those foundations about what good looks like. And then finally, my last point then is this will reshape our national safety and quality standards. So that means that every hospital in Australia that's accredited to these standards will need to be, it'll be mandatory for them to be adapting, to be using the national clinical governance model and the thinking in each of those foundations. So in summary, I think that's this is my last slide. This really is, the Commission in parallel with this work is also looking at how we define high quality care. And so we've got to put this in our model, but the summary is that I know there are many, many definitions of different domains of high quality care, but the one we've landed on is on the right-hand side. We're saying that patients receive care that's person-centered, safe, effective, accessible, and integrated or connected in a health service or a health system that's equitable, efficient, and sustainable. And the reason I want to end with this slide is that it is the purpose of all clinical governance activities. And when we see organisations losing sight of why they have these structures and these systems and these cultures, and they're not all oriented to delivering high quality care, that's when we see poor performance and when we see failings in the quality of care. So our hope and our vision is that we're much more closely connecting clinical governance with high quality care, and having that tighter linkage and connection will give it purpose. And it's also a natural way for organisations then to check all of the work that they're doing in different areas. Are we achieving our purpose? How is this helping these 8 domains of high quality care? So I'll end there. We hope to publish this early next year. We're thinking around March or April, once it's been approved by our board. We're doing our final round of consultations and then we're going to make final edits. It'll be an online tool, so you'll be welcome to look at it. It'll be freely available on our website, and then it will be backed up with some resources on our resource hub, which we will build over time. And then the longer term plan is to do things like to develop indicators so that we are giving health services measurement tools specifically in clinical governance so that they can check their performance. So we'll build, it's a very big piece of work that we will build to over time. So I'll stop sharing my slides and I'm very happy to take any questions.
I
Dr.
request
Prema? Yeah.
I request our participants to post your questions in the QA section.
I think we have 2 questions. Dr. Prema, would you like to start with those?
I don't see any questions, Dr. Anna.
In the Q&A section,
No,
I can
it's a
see.
chat. They say thank you for the amazing lecture, and I would like
But
to
there is one
Mr.
on which core indicators should be monitored to show the clinical governance performance.
Thank
There
you
is,
for the question. Yes, so you are one step ahead of us. So that is our next step. So we are going to use these 6 foundations as our domains, and then we will develop a set of indicators for each of those for health services, but we have not started that work yet. This will be further down the track. But the idea then is that these should be lead indicators. If we can come up with some, so for example, for the building a healthy workforce culture, if you have some indicators on organizational engagement and culture, and you combine that and triangulate that perhaps with data from HR on your retention or bullying and harassment or your staff turnover. These should be indicators that are lead indicators that tell you have a problem long before your big catastrophic failings happen. So that's the vision, but I'm sorry, I can't. I've got nothing more to say on that because that work will be done. It'll be a long piece of work. It'll probably take us another 12 or 18 months to start developing those.
Okay, there is one more question. Please give examples of tools for clinical governance.
So the sorts of tools we're looking at for each of these would be, I'm talking about practical resources. So for activities that you could do at an organizational level. So we're going to develop things like simple things like PowerPoint slides to communicate about this, board agenda papers, so sample discussion papers for boards or executive teams to discuss and run workshops. And then there could be a whole raft of things from like patient safety surveys through to measurement, through to guidance about good use of data. So and guidance on AI and virtual healthcare. So what I mean by the practical tools is there's going to be a whole lot of different practical short, sharp guidance, but it will have a natural home in the model, and it will be, I guess that forms the architecture or a logic. So when you're in an organization and you've got a million different quality improvement projects and pieces of work that you're working on, we're hoping that this is a very logical way to organize and categorize some of those different approaches. And to put them in a home that sits in clinical governance, so that that way it automatically is elevated. These are tools that are elevated to the level of an executive or a chief executive or a board. So those sorts of topics that need that level of organizational oversight.
Okay, thank you. There is one more interesting question from Pratish. I'm sure many of us would like to know about this. What are the challenges to clinician buying in the clinical governance?
So many challenges. So we just heard that. I guess one of the when we hear about especially doctors, not so much in allied health, and often nursing staff are drowning in all of this. But a lot of the medical groups felt that they were either excluded from this and didn't have a voice at the table, and there wasn't a strong clinical leadership voice at an executive level, or found it tedious and didn't think it was their job. So we heard both those things. So they were the challenges. If I was to go to the solutions, again, it's anchoring this back to purpose and the quality of care that is delivered. So if we start talking instead of processes and systems, but about outcomes and impact, and how this affects the care that's provided, that is the way, obviously, to engage clinicians. And we also in the model have an example of best practice. One of the things that we have under our effective clinical practice domain is that in an organisation, when we spoke to the really high-performing organisations, they often had an organisational chart that reflected dual accountabilities for clinicians. So you had not only your clinical responsibilities, but you also had your accountability and your responsibility for system improvement in your organisation. So you're a steward of system improvement. And the high-performing organisations captured both of those things in their performance, in their position descriptions, in their organisation charts. And we saw some lovely matrix structures. So, for example, hospitals in setting up their accreditation, their structures for accreditation and for implementation of the national standards, they may have a clinical lead and an executive lead for each of the 8 standards that we have in Australia. And when you've got the two leads sitting together in a nice sort of matrix structure, that's when we saw much more meaningful involvement of clinicians at a clinical governance level.
Right. Next question is from Swagatika. How to monitor clinical governance based on patient outcome?
Yes, I don't have the answer to that. That is the piece of work we would like to do, and we obviously need research from around the world to help to do that. But I would say that we're very big in the model on triangulating data or combining different data sources. And so, for example, when you're looking at the quality of care delivered, you want to be looking at, of course, patient-reported outcomes, patient-reported experiences, but you also want to combine that with perhaps your feedback and complaints data, and you might also want to combine it with then the staff or the workforce culture in that unit, in that ward, in that department. So we're very big on combining different data sources to synthesize and to draw together stronger conclusions. So I guess my comment on patient outcomes would be that is but one data source that you'd be looking at. I don't know if I've answered your question properly.
All right. There is one more question. The attendee says, thanks for the amazing session. My question pertains to the concern that was raised by the CEO in the first slide. How to
Yes.
sustain culture of safety when the rate of attrition is very high, especially in
Yes.
the nurse staff category, which makes the major chunk of our workforce.
Thank you for the thoughtful question. And I forgot. I'm sorry. I meant to come back to those interviews at the very end to reflect on how we hope this model and this approach will help these chief executives and these board members with sleepless nights. Our hope is that it gives them a level of assurance that they can be they can be running their organization so that everything is oriented towards high quality care rather than having corporate governance responsibilities or having a board meeting that is dominated by financial matters or legal matters, but by having, I think this is a way to test, are you focused on the right things in all your executive meetings and decision making? And so I would hope that you could use this to plan a calendar of board meetings for the year, for example. There's all sorts of ways you could do it. You could have the 6 foundations spread out throughout your meetings throughout the year so that you focus on one every 2 months, or you could be touching on each of them, or you could be asking for reports from your quality team aligned with these 6 foundations. So that's how we see it used. So to get specifically to your question about the poor CEO talking about sustaining culture, I think that this amplifies the need for the focus on culture. And because this is just the first signal to Australia's health system about the importance of culture, it will justify, and in fact, leadership teams will have to spend more time on this because it will be a requirement in the standards, in the next standards. So I think it's a much fresher and more contemporary way of looking at culture. And the other message I forgot to say that I should have said too, that the model stresses that a board and a leadership team are equally accountable for the culture, that for the care for patients as well as workforce. And it's the culture in both those areas, which, as we know, is completely connected and interlinked. So I think this would give them justification and reason to spend significant amounts of time on this. And there could be a point if you have a failing, if you've had a bullying and harassment or a high workforce turnover in a huge part of your hospital or your health service, then when I was talking about how the different wedges can flex and contract, according to situation. It might be a period where you have a leadership team entirely focused on culture for 6 months, nothing else, because that is the biggest risk to patient safety. So I think that the model gives you the flexibility to do that and the justification.
Yeah, that was beautifully answered, Ms. Gillian. Next one is from Adnan. How can a nurse transcend from his or her nursing practice to a quality officer if he or she likes to?
It's a really nice question, and I think it's so much of this is about systems thinking. And when you're drawing up, I mean, nurses are wonderful in these roles because they understand um, uh, uh, all of these things, these 6 foundations intuitively, and can translate what this means to then clinical care at the front line. I think that thinking about systems, culture, and structures, and how these at any level, whether it's at an individual level or a team level, a department level, or an organizational level, that's how that is the definition of good governance. And you can have it in a very small pocket. And then you can have it at an organizational level. And so I would encourage any nurses who are considering roles in quality or in governance, safe in clinical governance, to start thinking about what are the systems, what are the structures, and what's the culture needed to provide high quality care, and then to extrapolate that into then at a team level, at a department level, and then more broadly at an organizational level.
Right. Next question is from Mr. Sheikh. He says, your explanation is relating to national level. Can you please explain relating to private hospital with 100 beds capacity?
Yes. So this model is scalable. It should be just as applicable to a day hospital that only does cataract surgery and has one ophthalmologist and one practice manager and sees 50 patients a year. It's just those concepts are just as applicable to a tiny private day hospital as they are to a huge metropolitan hospital. These really are the principles of good governance, and they are absolutely scalable no matter the context. I guess I would just put the caveat that we've designed this for the acute sector. All of our consultation was for the acute sector, but we've had GPs, we've had primary care, we've had community health services, we've had virtual care providers. I've had approaches from different people around the world. I had a meeting with a team in Ireland last month who want to apply this for this sort of thinking to their whole health system and saying, well, actually, these principles would hold. So I would be nervous to say that. I think we need to do some consultation and check because there are different factors in different settings. But I would argue that those 6 foundations are equally applicable, no matter if you're in, and that's why we tested it in a small outback hospital in the middle of Australia that was very remote with predominantly Aboriginal patients versus the big metropolitan hospitals, and it was equally well received. And I guess what I would say is that there's some sentiment about it cuts through the noise. Sometimes when you have so many indicators, so many things you're thinking about, and there's a complexity, this is a simple, and it's not saying that that's not important. We still have to do all of those things, but this is an overlay that you can apply at any kind of organizational size or geography, I would argue.
Yeah, I absolutely agree with you. The clinical governance principles remain the same irrespective of the size of the hospital. Right.
Yes.
So next question is, what is the role of hospital committees and importance in clinical governance?
This is probably an example of one of the practical tools that we'll develop. We're going to have a play with what different structures could look like. So if you agree that these are the 6 foundations that you should be focused on, how do you then orient and structure your committees so that they're focused on those things? And also, how do you avoid silos? So you don't necessarily want a separate committee for each of these things. How can you have a chair of one committee also sits on another committee to cross-fertilize and help with that integration across an organization. So I think if you're designing, I guess structures are very important. So committees are the workhorses of the board. So you definitely want to think carefully about how your committees are structured. But then obviously structure is only one part. It's also the culture, and it's also then the systems you have to support all of that.
Right. The next question is from Dr. Amiraju from India. He's an assistant manager quality. He has a long question, like basically 3 questions. Which books or learning resources you recommend for building strong foundations in quality, patient safety, and clinical governance? Next question is, are there any internship or observership or short-term learning opportunities in Australia for international quality professionals? What exams or certifications or eligibility requirements are needed for someone like me to enter healthcare quality or clinical governance roles in Australia?
Thank you for the question. So for learning resources, I hope from next year you can come to our clinical governance hub on our website to learn more about this, but it will be very simple. We see our role as drawing to get thought leadership and drawing together a whole lot of complex literature and just having very simple 1 or 2 pages on guidance on all of this. We're just very mindful that our audience are so busy, and so we are not an academic institution. We are translating the evidence into practical guidance. So we do hope, you're welcome to keep checking the Commission's website on clinical governance. It's very quiet at the moment. We're hiding until we release all of this. I really there's the Cambridge Core series. I don't know if you've come across those, Elements of Safety and Quality. It's freely available. And they have literature reviews on hot topics in safety and quality. They've got one on governance and leadership. They have one on using data. They have one on culture. And it's nice. They're up to date. They release them quite regularly, and they're long, but it's a great starting point to get good references and further reading if you go to their reference list. And I think I highly recommend them. Internship opportunities in Australia. I guess that would be mostly through perhaps our universities, I would be guessing. We have like Masters of Health Leadership and Management programs, for example, at the University of New South Wales, where there is a lot of overseas students, and some of them are doing sort of structured placements. But I'm sorry, I'm probably not the best person to ask about that one. And then in terms of exams and certifications, so this is a really diverse field. I'm a speech pathologist. I have a master's in public health. I guess the thing that changed my thinking about all of this is we have the Australian Institute of Company Directors in Australia. I'm sure, I don't know where your equivalent is in India, but they're the governance body for all sectors, not just health, and mostly it's the corporate sector. In Australia, it's mostly mining and banking and finance. I did their course and their certification a few years ago, and I found that so helpful if you're really interested in governance. But I guess my story is just to illustrate that we all come at this from different angles, and there is no sort of standard certification. The Australian Institute of Clinical Governance runs a lot of courses and webinars they do that you can sign up for. Yes, so that would probably be my recommendations.
Yeah. Next is, what is the new in this model different from existing models?
So hopefully I addressed that in my presentation. Mostly this is contemporary thinking on best practice governance. So this is so from a governance perspective, this is things like having inclusive and representative governance. So concepts where you have where your board or your leadership team or your workforce reflects the communities that you serve. So you have the diversity in your governance and in your organizations. So I think that's a newer concept. Absolutely, the culture concept is much, much stronger. And then we touch on digital health, AI, and digitally enabled care. And we also have a focus on environmental sustainability. So I suppose there's some examples of new thinking. Maybe just to touch on AI and digital health, because I didn't spend much time on that. Our message is that this is an integrated core requirement of clinical governance, and this cannot be delegated to an ICT team, and that this should be seen as part of core business for boards in health services. We are really promoting an integrated governance model.
Yeah. There is one more question from Mr. Pranay from Kolkata. He says, I would like to know how energy efficient and eco-friendly measures can be taken in as a part of clinical governance.
We're not prescriptive about that, but the way we've addressed it is we talk about how boards and leadership teams are responsible and accountable for, and we're being very careful here. We don't get into renewable energy and solar energy and things like that, because I see that as that's corporate governance. That's not specific to healthcare. We're trying to talk about safety and quality. So for us, our message to boards and leadership teams is that they are responsible for unwarranted variation, understanding their data and where health services have unwarranted variation. And I guess this is from all my Atlas work on the Atlases of Healthcare Variation, but also specifically thinking about then finding areas where there is unwarranted variation that might reflect unnecessary care or overdiagnosis or low value care. So we're tying this back to you should have systems in your organization that help you identify when you might be offering care, low value care. And in that way, considering the carbon footprint of that care, and it's part of your broader sustainability responsibilities. So I guess my message is nuanced. It's about it's more about the quality of care, bringing it back to the quality of care rather than more broadly speaking about counting carbon.
Right. Thank you so much, Ms. Gillian. There are a couple of more questions as well that I can see, but they were already addressed by you in the previous questions, so I would like to skip those. So we are coming to end of this session. I really thank Ms. Gillian for sharing practical insights on clinical governance and global experience in clinical governance principles. We appreciate the participants and for making it more interesting by your interesting questions. We hope this session is a food for thought, and we encourage everyone to continue the discussions at your respective institutions as part of your clinical governance meetings or the monthly quality meetings. And we would like to thank everyone for your time here.
Oh, thank you, Dr. Prema. I'm Dr. Vijay Agarwal. I'm the president of CAHO, and my proud privilege to thank Gillian Giles for this wonderful presentation, as well as to the moderator, Dr. Prama Vediar. And we would like to present our certificate of appreciation to Madam Gillian Giles, and this will, of course, reach you. So once again, very hearty, I would say, welcome and to the CAHO family. I think that you would join that in due course. And also that today you presented the 60th webinar, which completes 5 years of our relationship with CAHO and ISQua. And we are really indeed very grateful both to you and to the organization ISQua. So thank you very much, guys. And let's now look at some of the more announcements. Preeta. So the next, of course, will be on the first Tuesday of the next month. We still have to get this thing, but this particular, you understand that every first Tuesday, we are motivating a lot of hospitals to start making it as a monthly quality meeting in their organization. And we are very proud that Vijaya Medical Educational Trust in Chennai, Mehta Hospital, Chennai, Ganga Hospital in Coimbatore, Medica Super Speciality Kolkata, Fortis Punjab, Rajgiri Hospital Kerala, Baby Memorial Kerala, Bethany Hospital Shillong, Sri Ranga Hospital Chengalpattu, AJ Hospital Mangalore, Bombay Hospital Mumbai, Nirmal Sai Hospital Chennai, Jabalpur Hospital Madhya Pradesh, Christian Medical College Vellore, CMC again in Ranipat campus. Of course, Tata Steel, Medica Hospital, Sagal Neo Hospital, Nazareth Hospital Shillong, and ILS Hospital Damdam. So my heartiest congratulations to all of them for observing this. Now, of our upcoming activities are, we have the Quality Tools and Techniques program on the 5th of December. Clinical audit is there on the 9th of December, and quality implementation in hospitals, the basic CPQIS program. Hospital infection control on 13th December, infection control link nurses course on the 19th December. So please make it a point to join. We have some on-site training programs on 12th of December on the antimicrobial stewardship and hospital infection control basic program on 20th December at the Dr. Mehta's hospital. The 12th December one is at the Trichy hospital. So we have a masterclass series, which is empowering clinical excellence, clinical indicators, dermatology and respiratory medicine. That is on the 5th of December from 4 p.m. to 5 p.m. Then masterclass on critical care nursing is getting started from the 6th of January, and it will be till 31st of March, every Tuesday from 7 to 8:30 p.m. I think extremely important masterclass, and very soon we may have the Society of Critical Care Medicine also joining us as a collaborator for this program. Now we have the announcement for the executive program on healthcare management, which is a, you can register and online, and the last date for application is the 31st January. Then we have the national certifying exam for infection control professionals, and the register online proctored examination will happen on the 7th of February. Then National CAHO Olympiad exam for professionals, compete, learn and shine. Mark your calendar. This is on 10th of January 2026. Then CDE series, we have really a number of them. Toxoplasmosis in India on the 6th of December. And we have the 102nd cytogenetic and molecular testing in myeloma. And then we have the mass spectrometry for microbial identification. That is the 103rd CDE series there. And we have a lot of excellence programs on endoscopy safety and facilitation evaluation, that is EndoSafe, in collaboration with ASP. Next. And we have iComply, which is the infection control and antimicrobial stewardship compliance in association with SafeCare and Diversity. And of course, our events, we have now the empowering healthcare through diagnostic excellence, that is the Diagnosticon, which is the 5th edition of the Diagnosticon on the 24th and 25th January in Indore, Madhya Pradesh. Please block your dates. And we, of course, will have our signature event, CAHO-Con, on the 10th, 11th, and 12th of April at the Chennai Trade Center Chennai. So thank you so much. And as you can see, we are really overwhelmed with the kind of programs that are being rolled out, but it only becomes meaningful when you all join. And I'm sure that both for the Diagnosticon in January and Indore, and then in Chennai, April. Hope to see you all in person there. So thank you so much.
Thank you.
And
Thank
thank
you,
you once
everyone.
again, Dr. Prema, and we
Thank
have
you.
Anna here. Thank you so much. Thank you, everyone.
Thank you. Have a great evening, everyone. Thanks.
Thank you. Thank you.